All right, there you go.
There we go.
Sorry about that. My computer was acting a little weird.
It really could have been mine too. It's fine.
All right.
And so is it pronounced Shania?
Shania.
Shania, okay. All right.
Yeah.
Wasn't sure. My bad.
No, you're okay. You're okay. Okay. So I'm gonna interview you because I'm doing a project on mental institutions. And then my teacher, Becca, she gave you the phone number so I can contact.
Yep, Becca's awesome, so.
Yeah, right? Alright. So I'm gonna ask you about like 15 questions if that's okay.
Absolutely.
Alright. So let's start by, what's your name?
Alright, my name is Shelby Nilsson.
Shelby Nilsson. And do you work at uni?
I do, yes.
Alright. What position do you work in?
My position at uni is a psychiatric technician.
Alright.
Most of us, we just go by psych techs for short. It's one of the various different definitions for a direct care staff. So I work directly with the patients.
Oh, you work directly. Okay, that's good.
Mm-hmm.
Let's see. What made you decide to work for uni?
For uni?
Yes.
So I've a little bit of history about me. I've worked in mental health for the better part of 10 years.
All right.
So I've been with uni for almost 3.
Uh-huh.
And what got me to uni was actually moving to Utah.
Oh, all right.
I'm from here originally, but we moved out to Denver, and I finished up my undergrad in Denver.
Uh-huh.
And I wanted to come out here to get my master's degree to be a therapist.
Oh,
and
all right.
I really like the program at the University of Utah. That's where I'm at right now. And uni was one of the places I applied at to get a job over here so I could move my family over here. And it was the first place I got a job. And so really it was, I'd never heard of uni before I actually moved back over here till I got the job with them. Because most of my time I worked out in Colorado, but I did some time down in central Utah. And yeah, so it basically worked for me for my schedule. It worked for me to be able to get through my master's program. And yeah, so really top end organization in this area. And yeah, so that's kind of what brought me here.
All right, that's cool. Okay, was this affecting, like, once you got into the program, did this, like, affect your mental health when working with the patients?
That's a good question because I'd say everything affects our mental health, in my opinion. So working with the patients while going through the program, basically it makes it so you're doing 2 full-time things. I'm full-time school and full-time work, and they're both in mental health. So yeah, definitely it has had some effect on me. And there's been some times that I've been a little drawn thin. And so, yeah, so it's had an effect. I've basically had to make sure I stayed on top of my self-care, stayed aware of of how I could get burned out. Because I got pretty close to burning out about a year and about 3 months ago. And because it was a little bit much, and I'd taken on too much for school as well. So just being aware of those things kind of really helped me to keep everything in perspective, making sure I was spending time with my kids, with my wife, and doing everything. Trying to keep that balance is what helped me the most for when it did affect me. I didn't go fully into depression per se. I know people who do go into depression or even have anxiety about such a schedule like mine. But yeah, for me, I didn't get that far because I recognized it, and so being aware actually helped me to recognize it.
Oh wow! Okay. All right. What hard experiences did you face while pursuing your career?
Okay, so one thing for me is, so let me ask a question so I can answer it best. Are you planning on going into mental health to be a practitioner, or is this just a report for this class?
I mean, I would like to, like, that's one of the things that I've been thinking, but this is also, like, a report for my project.
Okay, cool. So, for me personally, so when I was your age, I had no idea what I wanted to do, right?
Yeah.
I didn't know, if I would have been told I was going to be a therapist when I grew up, I would have said you're crazy, right?
Yeah, okay.
But for me, I realized what I wanted to do finally when I was in my mid to late 20s. So when I was about 26 or so, I realized that I wanted to be a therapist. I had a job in mental health at that point, and I got, and so I kind of was exploring my options and everything. At this point, I already had 2 kids as well. So for me, the biggest experiences for me were going back to school as a little bit older person to finish up my bachelor's degree, and then actually going through and doing the master's as well. For me, it's been a process because a lot of times people go into school and know what they want to do, things like that. I quit school after my associates because I just didn't want to know. I didn't know what I wanted to do. I didn't want to keep on pumping money into an education that I wasn't going to use. And so I took a break for about 5 years. And yeah, it was a struggle because I had to juggle being a dad, working full time. At the time when I went through my undergrad, I worked at another type of place, kind of like uni, but more focused on, it's more of a long-term type facility, because uni, I don't know how much you know about uni. Uni's a short-term stabilization hospital. So we get people in crisis a lot of times, and we help them with med management. We help them with the interventions for suicidality, different things like that, depression, anxiety that are really intense. And so where I've worked besides there is in more long-term. And for me, one of the biggest, hardest things for me is when I started getting patients that reminded me of my children. So working with 10, 11, 12-year-old kids back in the day when my oldest was about 5 or 6, and some of those kids are developmentally delayed. So they were on the same level as my kids. That was one of my hardest things, was like, oh my goodness, this is like the same interaction I had 2 hours ago with my own child.
Yes.
Because this early adolescent is very developmentally delayed. So it's just very interesting to see that.
Oh,
that was probably one of the hardest, that and scheduling were the hardest things for me.
Oh my goodness. All right. Wow. There's a lot.
Now, my oldest is now 11, so I get to watch him grow, and my younger 2 grow as well, while working with kids their own age. I'm a lot more used to it now. At uni, I work on the child unit, so I work with kids from as young as 4 up until 12. So basically my kids' ages. So I'm a lot more used to that now. When it first hit me, it was just weird. But yeah.
Oh my goodness.
I hope that answers that question.
Yeah, that answered it perfectly.
So I've had some just weird challenges that have been hard for me in that regard. So. All
right. Would you have picked any other career than the one that you currently have?
Yes. I don't think that there's always a perfect answer in career. But I actually think that a lot of these things were present back then. We just hid them.
Yeah.
So back in the day when we were sending folks just off and warehousing in mental institutions, we were basically just taking the person that, like, say we have an affluent family who one of their kids was back then classified as mentally retarded. They basically possibly could have had autism. They could have been suffering from autism. They could have had any number of different disorders that basically they're just trying to get away from, so they didn't have to live with that stigma around them from neighbors, from people around them. We know as well that in addition to people being sent off to institutions, sometimes people would just hide them in a closet, which is super sad, right?
Yeah.
That's one thing I like about in today's world. We have so many more different resources to help people. And that's when in mental health, we still have a huge stigma against mental health in our world. I grew up in a really small town in central Utah, and that fed into my own personal stigma I used to have against mental health. I used to think that people should just tough it out, right? But that's a big part of where I came from. personally and professionally, developmentally, was from back then to now, was actually realizing when meds are needed, when actual treatment is needed, when talk therapy can help, and all these different things. So I think it sucks that we have that history in the psych field, but it's an important history to understand, I think.
Yeah, I can totally agree. Does everybody have the right to say no when it has to do like with the procedure, even though they know that they will die if they don't get the procedure?
What type of procedure?
Like, oh my gosh. Like, not a procedure and say, but like, what if it has to do like with therapy or
What? I'm sorry.
if it like has to do with therapy?
Oh, with therapy.
Yeah.
Absolutely, people have the right not to participate in therapy. That's kind of interesting because therapy won't work unless you are participating. Unless you have an active participant, and there might be some people disagree with that, but in my opinion, there's across the lifespan, no matter what age you are, if you're not at least buying in somewhat, then it's not going to work. Change isn't going to happen. One of the first things that you learn in therapy and being a therapist and being a counselor is building what we call therapeutic rapport. So basically building up a relationship between the therapist and the client. Without having that, then that's actually the biggest vehicle for change, is having a rapport and having somebody buying into the treatment. There's a lot of studies that basically show that the type of therapy, I don't know how deeply into like different types of therapies you've studied, but one of the gold standards in today's world is cognitive behavioral therapy, or CBT. Basically, they've found that it doesn't matter if you're CBT, if you're person-centered, or a number of different therapies. What matters is that it actually happens and you get some type of treatment. So, without that buy-in, you're not even going to get to any point of where change can be made.
Ooh, okay, all right. Why do you think doctors back then started doing things, not giving consent to the patients?
Like lobotomizing and stuff like that?
Yes.
So, having worked with severely psychotic patients for a number of years, I understand why they did that. It was to get them to shut up.
Oh.
It was. There was quite a while that when the medical community believed that lobotomies, for example, worked, because the success rate of having a severely psychotic patient or severely violently psychotic patient coming at you who was then like lobotomized or even chemically lobotomized with drugs. Basically, they go from that to being more docile and calm, and basically they become the model patient. But I mean, at the same time, what's going on up top anymore? They've basically taken away anything of what that person was and turned them into a vegetable. So it worked, but it's at what cost? Basically, if you're forcing somebody into that type of procedure, and not every institution did that. I mean, I honestly don't know the number of how many times those types of things were done. I know there's research out there and stuff, but I don't even know how accurate all those numbers are. But basically, you're taking and you're forcing somebody to adapt, or forcing somebody into change when they might not even have the ability to consent to that change.
Right.
So a lot of times patients don't have that ability to consent. So it's kind of it's hard, because you have to, in that type of a sentiment, you have to figure out who, like you said, if the whole consenting to one of these things, if somebody's not all there, they don't have the ability to consent, somebody else consents for them, but at the same time, it can be kind of gross. That's why those types of procedures aren't done anymore. I mean, we still use drugs sometimes, pretty heavy antipsychotics, and it's essentially a chemical type lobotomy. We still do that sometimes, but it's not as permanent as sticking a giant needle into somebody's eye and severing parts of their brains.
Right.
So.
And do you think like the giving the consent still happens today? Because people are not still fully there.
Yes, it absolutely happens today.
All right.
So, people can be involuntarily hospitalized. Happens all the time, and usually it's done with their safety in mind or the safety of other people. So, there's people in psychiatric hospitals all across the country who are not there voluntarily, but they've either proven to be a danger to themselves or to others, and so we do sometimes take away freedoms that way.
All
and
right.
it's kind of we can get into a huge ethics debate about this, of how ethical this is, and I don't know if that's one of your next questions, but it's kind of interesting because everybody has their own opinion on that. How ethical is that?
Yeah, right.
Or if somebody's an adult, should we just let them hurt themselves or something? And it's really interesting because basically where it comes down on, for example, there's a patient of one of my colleagues who had to be hospitalized last fall, and yeah, because they were serious threat to harm themselves, and it's kind of hard because, well, they're an adult. Should we just let them?
Right.
Or should we do all we can to help them? So that's where we're kind of gauging these skills.
And do you think it's the same with a child who doesn't have a parent and is going into the hospital?
Child who doesn't have a parent will be a ward of somebody, even if it's the state.
Oh, okay. So it has to be by the state in order for them to do it.
Yeah, it would be by the state.
Okay.
So the caseworker would have control over that, and a treatment team of sorts would have control of that, consisting of a doctor, a therapist, a caseworker, and all these things. I've worked in a couple places that had mostly state kids, and it is a different dynamic, but it's still somebody else has say over them until they're 18.
All right. Yeah. Do you think that things are the same as they were before with the mental institutions?
Absolutely not.
All right.
Back in the day, if you were to go, I'm sure you asking about this, you've probably Googled and seen like the pictures of some of those institutions, right? Like they're just these ominous giant buildings.
Yeah, the asylums and whatnot. Yeah.
And so in today's world, it's a lot different because back then, I would be incredibly fascinated to see how it worked back then. To like go and tour one of those facilities. Yeah. Because there were some secretive things to some of them. In today's mental health landscape, it's so much different because we have the benefit of 140 or so years of psychological research to understand how what works, what doesn't work. We know that lobotomy is not the answer. We know that some of the early treatments aren't the best. And even if you're going back to Freud in the early 1900s, some of his treatments were incredibly unethical. And some of the things he did was incredibly unethical. But at the time, if we're giving full credit where credit's due, he was basically the father of psychology at the time and starting from nothing. So we can get a lot of positives about that and then kind of alter treatment from that for the benefit of whatever clients did in front of us. So one thing that's very important to keep in mind is if you're keeping a client-based approach, you're basically altering your treatment for the individual client who's sitting in front of you in whatever, and that goes for medical, that goes for psychiatric care of any type. You're basically trying to use what works best. For example, I've taken a couple classes learning about at least two dozen different theories and methods of doing mental health therapy. But basically, if I try and apply that same one of the therapies to every single client that I have, then I'm going to not be very successful overall. I'm probably going to have some results because they've shown to work, but it would be so much better to alter and use several different types of treatments for the individual client that will help them most. So we have a lot of benefits from research, from development of the field over a long time to help individual people. Right. And as far as the institutions go, we have a different setup where there's state ordinances saying we have to have X amount of staff for however many clients are there. For example, you have to have one staff for every 4 clients that's there. So these clients are actually getting a better level of care anyway because there's more and higher trained staff helping them. Rather than on those old psych movies, we see the big dudes in the white coats coming and just throwing down.
Yeah, so they're just like romanticizing the mentally ill.
Yeah, and that still happens, but it's a lot less intense than you'll see in some of those movies because basically we're very well trained on what to do. And even if a patient becomes violent, we know exactly how to stop them. And we have me and 5 of my buddies are there really quick to de-escalate the situation. Starting by talking, trying to de-escalate, but they're going to attack me, then I'm going to have to take them down. It's going to be really quick because we're really well-oriented and well-trained.
Right. And do you still get those people once in a while saying, oh, this is an asylum, this is...
Absolutely.
Right?
Yeah.
Okay.
Absolutely. And you're taking away all my rights, I'm going to sue you, all this, that, and the other. I've heard it all.
Oh, okay.
I'm going to attack you. I'm going to kill you down the road. All these different things. I've heard. I've worked. Another thing about me is I actually got my start in the human services field working at the Utah State Prison.
Oh, okay.
So I have 3 years of corrections experience as well as my other experience in mental health. So you hear every little possible negative thing that. This isn't right. You're taking away my rights. You have no right to keep me here. You have no right to even talk to me. I'm going to be violent. I'm going to punch you. I'm going to kill you. Stuff like that. Yeah, there's a lot of different things you hear.
Wow. And do you think that most of the mentally ill are like coming from the criminals?
No.
No? Okay.
Nope. Because if you think about it, we're so much more aware of what mental illness is now, and mental illness spans from somebody who has a small amount of depression or a small amount of anxiety to somebody who is dissociating, somebody who basically is seeing, or even schizophrenia, somebody who's seeing things that aren't there or hearing things that aren't there. There's such a wide array of what mental health means that I think sometimes the general public just loops everything in and saying this person has a mental disorder, when in all reality, probably more people than not could be classified with some sort of mental disorder.
Right.
Because, and that's kind of the way it is, because we have these catch-alls that we use to be able to diagnose, to get treatment, because there's some insurance carriers that force you to diagnose before you can even give treatment.
Right. Okay.
So we have some catch-alls and stuff for mental health or mental health disorders, and basically a lot of it's to check a box, some of those catch-alls, but yeah, there's I would say a lot more. It's probably a higher percentage in criminality. People who, like, let's say, who have been convicted of crime, probably a slightly higher percentage, if I was to guess, then I'm sure there's some studies on it that I haven't read, than the general population, but I doubt it's that much higher.
All right, well, I'm, like, learning so much about this, and it's great, Kate.
Good. Keep in mind, too, that people in the prison, they get out.
Yeah.
So the people who stay in prison forever is a very small percentage of people who've been convicted of a life sentence without the possibility of parole. So there's that. Most people who are in prison today will eventually be on the streets.
All right. Yeah.
Not to be uncomforting or anything. But
no. Yeah. I think I know the answer to this, because obviously, but do you think that the mentally ill want to be treated like everybody else?
Yes.
Okay.
So, and what do you mean? What do you mean? What does the mentally ill actually mean to you?
Honestly, when I look at a person, I don't look at them for like what they look like or on that. I just want to know the person, sort of thing. I'm not really like against everything. I always have an open mind for
Good.
what's in front of me. Yes.
Okay. Awesome. Because when we use that statement, I'm not trying to like be corrective or anything. When we say the mentally ill, it just like I said before, it means such a wide array of different people with different disorders.
Yes.
Or different. Not even some people hate the word disorder because it connotes something that controls you or something that's like inherently wrong with you. A lot of people with different mental disorders. I mean, sometimes they're going through a hard time and they're going to be able to get treatment, get better.
Yeah.
So.
Yeah, and that's one of the questions I was gonna ask you, because I was like, I didn't know how to address it, so that's why I keep saying mentally ill for like a wide variety. Yeah.
That's why I asked. Okay, and so to address that, like the question on if people get better, is that what you meant?
Yeah.
Yes, people definitely get better. There are some disorders that are either chemical or hereditary that people are going to have and need to be managed for their whole life. For example, bipolar. If you truly have bipolar disorder, then you have a chemical imbalance and you're going to have to take meds forever, or else you're going to have to deal with some very unpleasant consequences. But if a lot of the mental health disorders, say even substance abuse disorders or depression, anxiety, a lot of these things, most of these things can be treated and can be basically in remission. So we hear about people once an addict, always an addict, or something like that. It's not necessarily true. It just depends on how you view things. Some people do view that as true. I don't necessarily view that as true because I believe that people improve and people actually can get over it. It may still be something that's hard for you. Like, let's say if you've suffered from depression or anxiety for a long time, and you get treatment and you're improved on that, you may have more of a propensity to fall into a depressive state. But if you follow some of those steps and actually keep on working and keep up the active maintenance, you're going to be fine. Yeah. Or if you, even more so, if you have the awareness that you have that ability to go back into that deep stupor, that deep place, or that dark place, then you're more likely to get help if you start sliding again. So I look at a lot of these mental health disorders as being on a spectrum. So if you've heard of autism, if you've heard of the autism spectrum, so we have people at different ends of it, of how quote-unquote autistic they are. I view most mental health and most things as that spectrum. And most people fall somewhere on it. Maybe I just got depressed every now and again for some reason, or maybe I am in the deep throes of depression for 2 years, or for my entire life, for whatever reason, be that trauma, be that whatever has affected me. So I see it as a very. I wouldn't be going into the field of mental health as a therapist if I didn't believe that changes could be made in people's lives. That's basically what I'm getting to.
All right. Wow. So, okay. Do you think people are still afraid of the mentally ill?
Yes.
Yes. Okay.
I think people are nervous around just the idea of it. And I think people are judgmental about it.
Right.
I don't think it's as bad as it has been even 15, 20, 30 years ago. Maybe that's partial. But even in the field, those stigmas are still there. Even in the field of mental health, there are still people who stigmatize somebody with a certain personality disorder as being unchangeable or unhelpable or dangerous, when they're forgetting about that person still being a person. Yeah. So, and having the capacity of having a positive life or a successful life, and whatever that means to whatever person we're talking to. So that stigma's it's one of my professional goals, is to help break down some of those stigmas.
Oh, all right. Ooh, okay. How many patients do you usually get a month through a year?
That's an interesting question, because it depends on what we're qualifying as my patients. So I'm not yet an official. So this year I've worked as a therapist on the University of Utah's campus, but I was working in my practicum, and so at the same time when I was working at uni, we only have a capacity of about on the unit that I work on.
Yeah.
And about 150 in the facility total. So if we're talking about like whichever different mental health institutions I've worked at, it just kind of depends because patients come and go. Like I said earlier, uni is a very short-term facility, so we could cycle out our whole unit in 2 weeks, and that's not uncommon to do. I don't know that I have a full number for that. As a therapist, you can carry a load of anywhere from 8 to 12 on up to 50 patients, give or take. There's such a variance in how many clients I'll see. Where I'm going to be interning, I'm starting my internship with my program here in 2 weeks, and I'm going to have a caseload of about 8 to 10. But the kids that I'm going to be working with are longer-term kids, adolescents from ages 13 to 17, who are in an institutional type setting. But institutional is the wrong word. They're in more of a residential setting.
Okay.
It's basically a residential high school. So I will have them, but I'll also have contact with other kids as well. So it's kind of hard to say a direct number on that. Sorry, I can't be more clear on that.
Oh no, it's fine. It's fine. Do you get people from that study at the U to go over there, like, and get help?
Yes.
You do? Okay.
So the clinic that I've worked at for the last year at the U, it's really interesting because a lot of the clients that we had in that clinic were referrals from students.
Oh.
One of my we did presentations in my class on patients, and we very routinely had to have some of the students go sit outside during a presentation because they knew the client.
Oh.
So, for example, I met with a client over the last 6 months who I just terminated with 2 weeks ago, who a really good friend of mine had to go sit outside when I presented on her because they've been friends since they were like 5 years old. So, which also means that you have to be careful about boundaries and not talking about confidentiality things. If that was going to be the next question, if not, I'll just answer it now anyway. You have to be professionally aware of those types of things. Multiple relationships and just being professional not to disclose confidential things with other folks.
Yeah, I totally agree. That's why I'm studying right now in my medical assisting.
Okay, cool. Yeah, you have to. Those boundaries are extremely important. It's an ethics thing, and it could be a loss of licensure for anybody from a therapist to a nurse to a doctor.
Yes.
So.
Yeah, I agree.
Very serious things happen. I mean, you could be out of your job for not abiding by those ethics.
Right.
So.
Oh my goodness. Okay. And last question. Why did you decide to do the interview?
Why did I decide to do the interview?
Yes.
2 reasons. Because Becca's awesome, first of all. We have a lot of respect for Becca. She's one of my favorite in-laws.
Yeah.
Sister-in-law of mine. And I also, anytime I have an opportunity to talk to somebody about mental health, I jump at the chance because I think that, like I said earlier, I think there are still a lot of stigmas. As I said to you, one of my professional goals is to break down some of those stigmas. And if that basically a lot of times means talking to one person and spreading ideas about that it's not so deep, it's not such a dark, scary thing to talk about or to even be aware of. It actually helps people being aware of these issues.
Yeah, I
Knowing
totally
somebody
agree.
has an issue, it's not a bad thing. It basically gives them a support system. A friend of mine who I was talking to today, for example, who is a PhD student at the University of Utah, he is struggling through some stuff right now, and he was basically in bed all week. And just when I was chatting with him, he told me that, and that's just talking about that is what got him up and going. And then he went on a several mile run just after that. And so just actually having that awareness and talking about that is what helps affect change. And I really am a very strong believer in awareness helping with change. It's a small first step to help people understand and to help people spread some of these ideas. Yeah. So I was more than happy to do this interview. So.
Okay. Well, thank you so much, Shelby. Like, I learned so much by this.
Good. Did you have any other questions?
Those were all the questions I had.
All right. Good luck, Shania.
Okay. Thank you so much.
You're welcome. See ya.
Bye.